and I welcome you all to today's session. I hope I am audible and visible to you all. Okay, so let us start today's session that is based upon some previous questions that have come in the INICET examination. As displayed onto your screens, and I welcome you all to today's session. I hope I am audible. Okay, so the question number one, as displayed onto your screens, is a pediatric dentist restores the anterior teeth using a highly efficient material. Okay, this could be a consequence of which of the following material? And there's a picture associated, so it is basically a picture based question, and you can see in the picture that it is a case of basically sort of extensive carious lesions in a young child, and these are the primary teeth, especially the anteriors have been involved with sort of aggressive carious lesions, and it has been restored, means as the question says, the lesions have been restored with a highly efficient material, and you can see that all over there are black color stains on the restored lesions, as can be seen. There are black stains. Okay. The black stains onto the restored material. Now, the question is asking what is the material that has been used to restore these teeth? Is it stannous fluoride, silver diamine fluoride, sodium fluoride, or reinforced glass granoma cement? Now, this distinctive black discoloration gives you a hint that some sort of silver preparation is there. So, the material basically is silver diamine fluoride, SDF. It is a new form of material that is used in 38% concentration. Silver diamine fluoride. So, it is a source of both silver ions and fluoride ions to protect the teeth and inhibit the caries process. The 38% concentration is used. If we look at the various other possible questions that have come into the examinations related to this is what percentage is used? It is 38% silver diamine fluoride that is used. What is the amount of fluoride that is present in this 38%? It is 44,800 ppm of fluoride in this concentration of silver diamine fluoride. Now, this silver diamine fluoride is a single solution that is used for basically two purposes. First purpose is arrestation of the carious lesions. Whatever caries is there, it is excavated and the lesion is filled with that material. And second is it is anti-hypersensitive. So it has got two actions on the lesion. It is a FDA approved material and for two actions. One is caries inhibition, or more than inhibition, we can say caries arrestation. Whatever active carious lesions are there, it arrests them, and this also prevents dentinal hypersensitivity. These are the two modes of action for this. And it has been found that when 38% silver diamine fluoride is applied, it prevents 74% new caries development. There's a reduction in about 74% in the new caries development, and there is 96% decrease in caries activity. So whatever active carious lesion has been there, when we excavate and restore with silver diamine fluoride, there's 96% decrease in activity and 74% decrease in the development of new carious lesions. Now, how it is done? Application is done by removal of biofilm. The biofilm. Okay, we know that whatever carious lesions or even tooth surfaces are there in the oral cavity, they are covered with a dental plaque or the biofilm. So before application and excavation of this carious lesion, We have to remove the biofilm, and then there is a 3-minute application. 3-minute application of silver diamine fluoride. How much concentration and how much fluoride? I have already told you. 3-minute application with a micro brush. We do a 3-minute application with a micro brush for this. Okay. So we know that silver ions are present, fluoride ions are present. Silver is known for its antibacterial action. So these silver ions, they precipitate over the surface. They are antibacterial. So whatever carcinogenic bacteria are present in the lesion, they are inhibited. So it decreases the activity by 96% of the active carious lesions. Fluoride enriches the tooth structure, makes it more impermeable to the acid attack. So the 74% reduction is there in the development of new carious lesion because fluoride is present. So both silver and fluoride ions are present. And because of the precipitation of these ions, the open dentinal tubules are somewhat blocked. So it is also an approved agent for treatment of dentinal hypersensitivity. And this material, that is silver diamine fluoride, is basically used in underprivileged areas where the access to the full dental care with modern equipment, rotary instrumentation is not available. So simple hand excavation, removal of the biofilm, and application with a micro brush is done for silver diamine fluoride. The only potential disadvantage is that there is a prominent black discoloration of the teeth, and so it is a highly non-aesthetic material, and it is usually used for treatment of primary teeth with active carious lesion in underprivileged areas where the access to the full dental care is not possible. And they have a duration of action. This duration of action for silver diamine fluoride is nearly 24 months. It's not a permanent inhibition. Whatever action inhibition of lesions, prevention of development of new lesions takes place is for a period of about nearly 24 months. Okay. So these are the different aspects of silver diamine fluoride, potential questions that can be asked or that have been asked related to this material, silver diamine fluoride. Okay. Now we proceed to question number 2 as displayed onto your screens. The zone of wheel is cell-free zone, cell-rich zone, odontoblastic zone, or the central zone. So basically it is talking about the morphologic zones of pulp. What is talking about? It is talking about morphologic zones of pulp. Okay, zone of wheel. It is a very simple and straightforward question. All of you must be knowing is basically the cell-free zone. So answer would be option A to this question, cell-free zone. Okay, if we look at the related aspects of whatever we have already seen in the different sessions, that the pulp is morphologically divided into 4 zones. Okay, we normally study the pulp and divide it into 4 zones. From outside to inside, we divide them the outermost zone of the pulp. The outermost zone of the pulp is the odontoblast layer. We know that the pulp organ of all the teeth is outlined by a single layer of cells called odontoblast. Unilayer or single layer of odontoblast outlines the pulp organ from the crown to the apical area. Okay, the first zone is the odontoblast layer. Okay, and the second zone is the subodontoblastic zone. That is the subodontoblastic zone, that is known as zone of wheel, and it is basically a cell-free zone. No cellular elements are present in this zone, that is nearly about 40 micron wide below the odontoblast layer. No cells are present, that's why it is called cell-free zone of wheel, and it basically contains non-cellular elements like nerve fibers, which are mostly non-myelinated nerve fibers. It is in the periphery of the pulp below the odontoblast layer. The zone of wheel is present. It basically consists of nerve fibers, which are called non-myelinated nerve fibers. Then there are blood vessels or capillaries present, and there are certain cytoplasmic process of dendritic cells. Okay, we know that dendritic cells are the antigen presenting cells which are present in the next zone, but the cytoplasmic processes may extend. So actually no cellular elements are present, but these structures, nerve fibers, fine blood vessels, and these cytoplasmic processes are present in the subodontoblastic zone of V. The third zone of the pulp from outside to inside is the cell-rich zone. Cell-rich zone. This zone is also known by the name that is zone of Hall, HOHL. So if you get a question, what is zone of Hall? It is another name for cell-rich zone. Okay. As the name indicates, cell-rich zone, all the different cellular elements of the pulp like fibroblasts, the dendritic cells, the macrophages, the lymphocytes, and other cells. Whatever cells acumens are present, especially we would talk about some cellular elements like undifferentiated mesenchymal stem cells. So after the fibroblast, these undifferentiated mesenchymal stem cells are the most prominent cellular elements of the dental pulp, and they're present in the third zone, that is the cell-rich zone. And the fourth zone, the innermost zone of the pulp, it is called pulp proper. It is called pulp proper. It resembles a loose connective tissue. So histologically, what type of tissue is dental pulp? Dental pulp is a loose connective tissue. So these are the four zones of the pulp in brief related to the question that we are discussing. What is the zone of wheel? Second zone, that is the cell-free zone. Okay. Question number 3 as displayed onto your screens. The best isolation when performing vital pulp therapy is another straightforward question. Vital pulp therapy involves procedures like direct and indirect pulp capping and pulpotomy. Okay. Rubber dam, cotton rolls isolation, saliva ejector, or swab doctor. So there is no doubt about this that whatever is the procedure, clinical procedure we are doing, that rubber dam isolation, option A would be the answer, is the best method of isolation for anything. Saliva ejectors and cotton rolls and spheadopter, they are all accessory methods. They are all accessory methods of isolation. So best method of isolation, please do not get confused with any of the technical terms like spheadopter, etc. Okay. Rubber dam is the first choice answer for almost all clinical situations. Without exceptions, there can be specific contraindications for usage of rubber dam, like a patient is allergic to rubber, latex hypersensitivity. Then also we have got substitutes like nitrile or vinyl material can be used. A patient who is asthmatic, has difficulty in breathing, is a relative contraindication we would avoid because the patient would be panicky. At times, the patient breathes through the mouth. So, in such situations, for asthmatic patients, we would avoid using a rubber dam. Otherwise, it would always be a first choice answer. So, there is no specific local procedure based contraindication for application of rubber dam. Question number 4. There's another picture based question. We have to identify something that is given over here. So what you can see that there is isolation of the upper anterior teeth and a device has been placed. Okay. And you can see this device has got two components. One is touching the tooth and another there is a lip clip. Okay. and various readings are seen. So what is this device? Diagnodent, electric pulp tester, apex locator, or laser Doppler flowmetry? I think without any confusion, you can answer this, that this is an electric pulp tester. The device that is being used is an electric pulp tester. So please do not get confused. If at all someone is confused with the lip clip over there, it is not an apex locator. Okay. Even though a lip clip is there, this lip clip has got a function of completion of circuit. It helps in completion of the electrical circuit. Okay. The lip clip. So there is a complete circuit formation and electric pulp tester is used. Related to electric pulp tester, another set of questions that are placement. Then it should be done in the areas of highest neural density. It should be done in areas of highest neural density. Okay. The placement should be done in the areas of highest neural density. And for highest neural density, for anterior teeth, what is the site for the preferred site for the placement of electric pulp tester? It would be incisal edge. Okay. And for posterior teeth, where will we find highest neural density? It is for the cusp tips. Sometimes they ask you about the distinction between the different cusp tips. Then we know that the highest pulp horn is of the mesiobuccal cusp. So it would be the mesiobuccal cusp tip for the placement of EPT electrode in cases of posterior teeth. And what is the target? The target is the A delta sensory fibers. This is the target for the placement of getting result from the electric pulp testers. So we excite the A delta nerve fibers which are present in the periphery of the pulp, and they are mainly excited by placement in the areas of highest neural density where the pulp horns are closest to the surface. So for anterior teeth, it would be in the region of incisal edge, and for posterior teeth, the cusp tips, and the highest pulp horn is below the mesiobuccal cusp tip, whether it is for the maxillary or the mandibular teeth. So that would be the cusp tip of choice for placement of electric pulp tester. And it is basically a sensitivity test. EPT is a sensitivity test. Okay, it relies upon the sensory innervations of A delta nerve fibers, so it is not a true vitality test. So there are high chances of false positive and false negative results with electric pulp testers. So if we talk about the accuracy of the pulp sensibility test, three principal pulp sensibility tests are there: cold test, heat test, and electric pulp testing. Out of these sensibility tests, okay, the highest accuracy is with the cold test, and the medium accuracy is found with the electric pulp tester, and the heat test is the least accurate of the three type of pulp sensibility test. So they all rely upon the sensory innervation of the dental pulp. They are not the true vitality test. True vitality tests are the ones like laser Doppler flowmetry. It is a vitality test. Okay. All these Diagnostic, EPT, application of laser Doppler flowmetry, electric pulp tester is a sensibility test, relies upon nerve fibers. Diagnostic, laser Doppler flowmetry, they all rely upon the presence of vital blood circulation in the dental pulp. So two set of tests are there: sensibility test and vitality test. Coming over to question number 5. The classification of pulpal diseases according to AAPD. AAPD means American Association of Pediatric Dentists, includes all except the classification of pulpal disease according to AAPD, which is not there in the classification. Acute pulpitis without pulpal necrosis, irreversible pulpitis with pulpal necrosis, acute irreversible pulpitis, and reversible pulpitis. Now, even if you are not aware with this specific classification according to AAPD of pulpal disease, you can answer this question by looking at the terms. It is talking about acute pulpitis without pulpal necrosis. Okay, definitely it can be a classification. There's acute inflammation of the pulp, but the pulp is not necrotic. That is a possibility. Firstly, there is reversible pulpitis, then there is irreversible pulpitis, and then there is pulp necrosis. So, acute pulpitis without pulp necrosis, irreversible pulpitis with pulpal necrosis. Now you can see the terms used. Here it is written acute pulpitis, and here it is written irreversible pulpitis. So technically speaking, whenever we use the word acute, it always signifies irreversible. Okay. So these two words cannot be used together. Acute always means irreversible with respect to the pulpal diseases. Remember that. Okay. In the modern endodontic terminology, acute is interchangeably used with that word irreversible. So you can see the options A and B. They are using the term acute and irreversible respectively, and they signify the same clinical condition, that is what? Irreversible pulpitis. But it can be with necrosis or without pulpal necrosis. So both options A and B are correct. Now, as we have discussed already, we come to the option number C, acute irreversible pulpitis. I have told you these two terms are interchangeable. So there is nothing called acute irreversible pulpitis. If we mention something as acute irreversible pulpitis, then there has to be something called acute reversible pulpitis. Isn't it? To justify this term, there has to be a diagnosis of acute reversible pulpitis, but that is not the scenario. Always remember, acute means irreversible. So option C is not correct. Reversible pulpitis is a separate term, is correct. So option A, B, and D, 1, 2, and 4 are correct. Option 3 is not correct. In any of the classification system, it is not correct. Yes, if we read about some very old texts like initial editions of Grossman, etc., their pulpitis used to be distinguished into acute reversible, acute irreversible pulpitis. But the contemporary practice does not support the terms. Acute always means irreversible. So remember this system of classification of pulpal disease. So acute irreversible pulpitis is not there, and there is nothing called acute reversible pulpitis. It is either reversible or acute. Acute is irreversible. Coming over to question number 6. The generation of file cross-section seen below, another picture-based question. There is a rotary instrument given over here, and we have to identify the generation. Options are fourth, fifth, third, and second generation. For answering this, you should be knowing the generations of nickel titanium instruments. There are basically 5 generations. Okay. And this classification was given by Hepsalo and Chen. According to Hepsalo and Chen, there are 5 generations of nickel titanium. The first generation, they are passive instruments with an important factor, that is radial lens. Passive cutting instruments with radial lens. So if we make a cross section of this instrument, of a first generation instrument, The question is showing you cross-section of an instrument. The first generation instruments, they would be having a U-shaped cross-section. They are passive cutting instrument with radial lens. We can see the edges of the blade, they are blunted. This is known as a radial lens. The edges of the blade are blunted. The second generation of nickel titanium instruments, they are active cutting and without radial lens. Active cutting without radial lens. So if we have to look at the cross section, you get a figure like this or like this. Okay, or like this. Okay, different blade geometries are there, but what is most common thing in them? They are without radial lens. They have got sharp edges on the blade. They all belong to the second generation of nickel titanium instruments, which are active cutting. You can see the blades are sharp, so they would more efficiently and effectively cut dentine as compared to the first generation instruments. The third generation, they require special heat treated. They are also nickel titanium instruments, but special heat treatment is given to them. This special heat treatment enhances the properties like cutting efficiency as well as their fracture resistance. Special heat treated instruments. Some of the important examples we can CM files, high flex CM files, or twisted file. Okay. High flex CM file. CM stands for controlled memory. So they require a special heat treatment. I would not go into the details of the nickel titanium alloy right now, but you should remember the generations, they are special heat treated. Two principal forms of nickel titanium are the martensite and the austenite form. We all know that. Apart from that, when we give a special heat treatment, additional phases like R phase are formed, MY are formed. So all these different forms of nickel titanium, they enhance the clinical characteristics, make them better instruments. Fourth generation, they have alternate movements. Alternate movements. These nickel titanium instruments, they have got alternate movements. Means either they would move up and down. Instead of rotating inside the root canals, they would move up and down. Or they would reciprocate. Move to and fro. Move up and down. An important example of up and down movement instrument is self-adjusting file, SAF. Reciprocating is wave 1 and reciproc. These are two prominent examples. And finally, the fifth generation instruments, they have got offset design. Offset design. In the cross section, this you can see in the figure, they have got offset. What does the figure marked with, point marked with X indicates? X indicates the rotation axis. Axis of rotation of the instrument. You can see the axis of rotation of the instrument is not coinciding with the center of the instrument. So these instruments have got a offset design. This offset design gives these instruments a snake-like or swaggering motion inside the root canal. They have a special motion called swaggering motion. Which instruments? Fifth generation of instruments as shown in the figure. So what would be the answer to this? They are the fifth generation of instruments. This particular cross section is indicated by our offset design. The center of the instrument does not coincide with the center of rotation of the instrument. They rotate on an eccentric axis. That's why they are called offset design instruments. They have a better centering ability inside the root canal. They have a snake-like or swaggering motion. Example of this instrument is ProTaper Next. ProTaper Next. Some prominent examples. Okay, Simply ProTaper, Race. These are examples of second generation instruments. And the first generation instruments, three prominent examples you can remember are Lightspeed, Profile, and GT files. The first generation. So I have also given you examples of some of the prominent instruments in each generation. Coming over to question number 7. The rubber dam clamp shown here is, what is the type of rubber dam clamp that is shown in this picture? I would enlarge the picture for you guys, and you can see there's a bow, two jaws, etc. there. Options are, it is a winged with bow, winged without bow, wingless with bow, or wingless without bow. I think it should be easy to answer. Okay. This is the bow of the rubber dam clamp. This is the jaw. And this is the hole for engagement of forceps. So it is basically a wingless clamp. It is a wingless with bow. Definitely bow would always be present in a rubber dam clamp. Had it been a winged clamp, it would be having structure or configuration like this. A bow, two jaws. This would be the bow. This would be the jaw. It has got 4 prongs. These points of the jaw, they are called prongs. These extensions of the jaw are called prong. Hole for engagement of what? The forceps, and it has got 2 set of wings. These are the wings. The geometry or the configuration of a winged clamp is something like this. These wings are 2 pair of wings, an anterior pair of wings and a lateral pair of wings. Anterior and lateral wings. Okay. Winged clamps and wingless clamps. So this would be a winged clamp. This winged clamp, it has got certain advantages as compared to wingless clamp. 2 important advantages are, it causes better tissue retraction. Okay, these wings, they compress the gingival tissues more efficiently as compared to wingless clamp. So there is better tissue retraction, better isolation. Okay, it provides more stability. So these are the 2 prominent examples of these advantages of winged retainers. If we talk about the disadvantage of winged retainer, definitely they interfere with matrix band placement. We know that matrix band is something that creates a temporary wall for the condensation or placement of restoration. So these matrix band usually encircle the tooth either 180 degrees or 360 degrees. So these winged retainers, because of the wings present, they interfere with the matrix band placement. And secondly, they cast a radio opaque shadow on the radiograph. Okay. So at times they would obscure the vital details when we read a radiograph. These wings, there are 4 wings in a single clamp. When we expose a radiograph, due to angulation difference. A major section of the tooth and the adjacent tissues may be obscured with the radiopaque wings that can interfere with the important diagnostic information that we are looking for in the radiograph. So these are the advantages and disadvantages of your wingless and winged retainers. So what would be the answer? It is a wingless with bow. Option 3 would be the answer to this question. Coming over to question number 8. A 10-year-old child was brought to the clinic with complicated crown fracture of 1-1 and 1-2. Complicated crown fracture. So the first set of information, second set of information, and there's an abscess formation with respect to 1-2, third set of information. The X-ray reveals the following changes in relation to 1-1 and 1-2. Means the question is talking about two central incisors in a 10-year-old child, two maxillary central incisors. The vitality test of 1-1 proves negative. The fourth set of information, how will you manage the patient? It is asking about the treatment plan. So what information can we get from the different sets of information? Firstly, it is talking about age of the child that helps in determining the maturity status of the teeth. We know that the eruption age of the maxillary central incisors is in the range of 7 to 8 years. And after eruption, it takes 3 years for the root formation to complete. So roots are completed by the age of 10 to 11 years. So since it is a 10-year-old child, the root may have been completed or may not be completed. We have to see the radiograph for that. Complicated crown fracture means there is pulp exposure. Crown fracture can be non-complicated and complicated. Complicated means there is exposure of enamel dentine with pulp being exposed to the oral cavity. Simply enamel and dentine, it is non-complicated crown fracture. So pulp is exposed in both the central incisors. There's an abscess formation with left central incisor. So why would an abscess form? The pulp is necrotic, isn't it? It is inflammation of the pulp due to exposure, then degeneration of the pulp, the infection goes down and the pulp necrosis there. So non-vital tooth basically. 1-2. Okay, and vitality test of 1-1 proves negative, but also 1-1 is non-vital test. How will you manage the patient? Now look at the options. RCT of 1-1 and epixification of 1-2. RCT of 1-1 and revascularization of 1-2. RCT of 1-1 and extraction of 1-2, extraction of 1-2 and 1-1. Now, when vitality test is negative, this also indicates pulp degeneration. So definitely both 1-1 and 1-2, according to the information given in the question, they require some sort of endo intervention. Vital pulp therapy would not do. Okay, with 1-2, there is abscess formation. So pulp is definitely degenerated. The response to the vitality test is negative with 1-1. So pulp is also irreversibly denatured. So what we have to do? We have to do RCT in both the cases. Okay. So they both require root canal treatment. Now, options are RCT of 1-1 and epixification of 1-2. RCT of 1-1 and revascularization of 1-2. RCT of 1-1 and extraction of 1-2. So we look at the options. RCT of 1-1, RCT of 1-1, RCT of 1-1, they are correct, isn't it? Because definitely 1-1 would require root canal treatment. Now 1-2, they are talking about there is an abscess formation over there. And we can see there is mildly open apex. If we look at the radiograph carefully, there is a mild open apex formation over there. So we are left with options like epixification of 1-2 and revascularization of 1-2. Extraction of one tooth or extraction of both the teeth, we would rule out. So option 3 and 4 are ruled out because that is not the right way of management. We would not extract any of the teeth. We are left with options 1 and 2, and both of them are feasible treatment options for the above situation. But if we look at the more biologically based procedures, then regenerative endodontic procedure is preferred over epexification. Always. So, what type of tooth is this? 1, 2. 1, 2, the diagnosis would be an immature pulpless teeth. There is abscess formation and the apex is not formed. So, immature pulpless tooth is 1, 2. And the best treatment for an immature pulpless tooth is always regenerative endodontic procedure as compared to epexification. Why? Because epexification is definitely a feasible option, but it would simply form a calcific barrier. It would not induce any root elongation. It would not induce any constriction of the apical, 1/3, and it would not induce any increase in thickness of the walls of the pulp. All these factors would favorably be found with regenerative endodontic procedures. So they are better and more clinically acceptable treatment options whenever feasible. So we would stick to answer number 2 for the above question. I hope all of you understand. We have to look at the question, see the marker words over there, the information that is being sought, and then we have to answer accordingly. So it would be option 2, RCT of 1, 1 and revascularization of 1, 2. Next question. 9-year-old child, again a sort of clinical history based question. 9-year-old child fell down while playing and lost her upper front teeth and reported to the clinic. What is the treatment done to the patient, and identify the condition shown in the X-ray image? Okay, so we can see some sort of trauma is there, as a lot of blood we can see over there, and some sort of splinting is there, which is clearly identified. A splint has been placed. So, and this is the post-operative radiograph of the patient that has been done. We can see that the root canal is also done with both the teeth. So we have to identify the sequence of treatment: replantation, splinting, RCT, and replacement resorption. Replantation, splinting, RCT, and inflammatory resorption. Replantation, splinting, RCT, and internal root resorption. Replantation, splinting, RCT, and revascularization. So if we look at the sequence, RCT and revascularization, this sequence is never there. Okay. Whenever we attempt revascularization, root canal is not done over there. Simply pulp extirpation is there, and then we induce regenerative endodontic. So this option we can easily rule out. This sequence would never be there for any of the clinical condition. Now we look at other options: replantation, splinting, replantation, splinting, replantation, splinting. So definitely the question is telling the child has lost the teeth have been replanted back. And once we replant the teeth, they are splinted. And if I talk about the duration of splinting, it is a case of tooth avulsion. What would be the duration of splinting? 1 to 2 weeks of splinting. What type of splinting? What would be the nature of splinting? It would be semi-rigid, which is also called physiological splinting. Semi-rigid or physiological splinting. RCT, definitely the third step. Okay, whenever there is a case of tooth avulsion, RCT is done after placing the tooth back into the socket, replantation and splinting. So we replant it, stabilize it with a splint, and do root canal. So these three things are the same with all the three options. Now we have to look for the fourth thing, replacement resorption, inflammatory or internal root resorption. To identify it, we come to the radiograph and study it properly. Option 3 says internal root resorption. Do we see any internal root resorption over there? No. There is no enlargement of the root canal. If we see the obturated root canals, they are continuous. Conical root canals. Had it been a case of internal root resorption, the root canal outline would have been like this. Internal root resorption. So we rule out option number 3 also. So to answer such questions, it is always best to go with the method of exclusion, because there, as we have seen in the previous question also, there can be multiple treatment options for a particular clinical situation, which are all technically correct. So if we just arrive at a one particular answer in a orthograde manner, we are likely to get a wrong option. Method of exclusion is always the best to do in such cases. We have excluded options number what? 3 and 4. Now replacement resorption and inflammatory resorption. What is the difference between these two, replacement and inflammatory resorption? They are both types of external resorption. This is also external resorption. This is also external resorption. Now what has happened in this clinical situation? We come to the diagram over here. Okay. We can see the root outline of the tooth. Firstly, we have seen the root canal outline. Now we see the root outline. We can see they are in a post-operative radiograph. Complete root outlines are there. So whenever there is a case of external inflammatory root resorption, the root outline would not be complete. There would be shortened roots. Roots would be shortened. Here the roots are not shortened, so it is not inflammatory resorption. Replacement resorption, we have to identify the lamina dura. Okay. If I remove the markings that I have done, you can see in the radiograph that apical 1/3 area. In the apical 1/3 area, the lamina dura is not clearly identified. Why the lamina dura is not clearly identified? Because there has been replacement resorption, the fusion of the tooth with the bone. So whenever there is a case of tooth avulsion, it has been successfully treated with replantation, splinting, and endodontic therapy. There are two potential outcomes of them. Either it is external inflammatory resorption or it is replacement resorption. Whenever external inflammatory resorption occurs, there is failure of the treatment. Whenever there is replacement resorption or ankylosis occurs, it is considered to be partial success of the treatment. This case, we see completely formed roots, obturated roots, but some disturbance in the apical lamina dura. So it is option 1, the answer, the best possible outcome that is shown over here. Okay. I hope all of you have understood this. Okay. Question number 10 is displayed onto your screens. What? A patient complains of pain in the right lower back region of the jaw on eating ice cream. Pain on cold. She does not provide any positive history in other conditions. IOP image is given below. What should be the treatment plan for her? So there is a pain on stimulus. Pain on cold stimulus. And there is no spontaneous pain. So this history and the radiograph, we see this is the deep carious lesion that is almost approaching the pulp but not involving the pulp. So it is a case of deep carious lesion with open pulpitis. Definitely patient would be having heightened sensitivity to the stimulus like cold because a lot of exposure of the dentinal tubules is there. But There is no spontaneous pain. There is no irreversible pulpitis. There is pain on cold stimulus indicates reversible pulpitis. So what we would do without looking at the options, we would attempt some form of vital pulp therapy and we would not do root canal. Even without looking at the options, we can outline the treatment. Now we look at the options. IPC on forceps, that is indirect pulp capping, RCT on forceps, sensitivity toothpaste, and extraction of forceps. Root canal and extraction are ruled out. Sensitivity toothpaste, no, it is not a case of dentinal hypersensitivity. It is a case of deep carious lesion approaching the pulp, causing pain on cold stimulus. This would be of no help. We are left with vital pulp therapy option, that is indirect pulp capping. We can see no frank exposure of the pulp is there. We do indirect pulp capping with forceps. So option 1 would be the answer. Next question. A 10-year-old child came to the dentist. So we can see there's a distinct difference in the pattern of the examinations, NEET MDS examinations, as well as INICET examinations. The questions are more clinically oriented. They would give you a short history. More challenging questions are there in INICET examinations as compared to your regular NEET examinations. Another history based, a short history is given. 10-year-old child came to the dentist with a history of blue-gray tetracycline staining with bending and the wants to get rid of the stains. What treatment will you suggest? 10-year-old child. Okay. Blue-gray tetracycline staining. At-home bleaching, full crown restoration, hydrochloric acid microabrasion, या superoxol with and without heat. We know that any form of bleaching would not do in such cases of blue-gray tetracycline stains with bending. Bleaching treatment respond to mild yellowish brown discolorations of teeth, that too without bending pattern. Here, deep blue-gray discoloration is there with bending that would not respond to any form of bleaching, whether it is spa bleaching or at-home bleaching. So we rule out options A, 1 and 4. Now two options, hydrochloric acid microabrasion and full crown restoration. What is microabrasion? It is used for superficial stains. Okay. Superficial stains. Superficial means that are 0.2 to 0.3 millimeter inside enamel. Superficial stains. Here, there are blue-gray tetracycline staining with bending patterns. So definitely they are deep dentinal stains. We know that tetracycline staining is always deep-seated from within the tooth structure, which is deep dentinal stain. So again, hydrochloric acid microabrasion would not respond. The only option that we are left that can give a good clinical outcome in such cases is full crown restoration. Option 2 would be the answer. So again, I have answered it based upon the method of exclusion, isn't it? Instead of arriving at the or jumping at the conclusion, we should exclude the incorrect options. Question number 12. What will be the first step in the management of this patient who's having root fracture in mandibular anteriors? Let us see. Okay. What would be the first step in the management? We can see that there is some fracture evident over the cervical to the midroot area. So it is a case of horizontal root fracture. It is a case of horizontal root fracture. Revascularization, splinting, RCT or extraction. What is the first step? So if we encounter a case of horizontal root fracture and we are seeking that we have to save such a tooth, the first step would always be stabilization, splinting of the tooth. And splinting, what would be the duration of splinting for root fractures? It would be 2 to 4 weeks of, again, semi-rigid splinting. 2 to 4 weeks. Exception would be cervical, 1/3 root fracture. When there is a cervical 1/3 horizontal root fracture, we have to do the duration of splinting would be 2 to 4 months. Okay, so this is an exception that you have to remember, because cervical horizontal root fractures, they have got the worst prognosis. The best prognosis is for the apical 1/3, followed by the middle 1/3, and the cervical 1/3 has the worst prognosis. And if at all we are attempting, then the duration of splinting has to be nearly about 2 to 4 months, and that too at times with a more rigid splinting. Otherwise, it is always semi-rigid or flexible splint for 2 to 4 weeks. So option 2 would be the answer, the first step. We would never attempt revascularization because it is not a case of open apex. Root canal can be done because pulp necrosis occurs in 25% of the cases of horizontal root fracture. Root canal would be done at a later stage always, depending upon the pulpal diagnosis. But the question is asking you about the first step. So whether it is apical, middle, or the cervical 1/3 of root fracture, whenever we attempt to salvage such tooth, the first step would be splinting. And what is the type and duration of splinting? I have told you. So option 2 would be the answer to this question. I think this was the last question for today's session. So these were the important questions related to my subject of cons and endo that came in the 2023 INICET examinations. With this, I conclude today's session. I hope it has been comprehensive and you have been able to understand. One important thing I would like to say that these INICET examinations, they give most weightage in my subject to endodontic traumatology. You know that we have also seen out of the 12 couple of questions, 3, 4, 5 questions may be related to endodontic traumatology. And in traumatology, the important thing is that we have to read the clinical status, the age of the patient, the different clinical signs that are given so that we arrive at a proper conclusion of diagnosis and the treatment plan. So with that, I conclude today's session. Thank you very much for being connected with me. Happy reading. Good night, everyone. See you again in the next session. Thank you. Yeah. Someone is asking me about splinting via. See, whenever endodontic traumatology and splinting is concerned, we always use a special splint called titanium trauma splint, or we use your splinting wires. Okay. Ortho wires are usually not used. We can use a 26 gauge or at max a 23 gauge wire. Okay.